Hello, my name is Susan Hepburn, and I'm a clinical psychologist and professor in the Department of Human Development at Colorado State University. And today I'm really pleased to be talking with you about a very, very complex topic. What should we do in the educational identification process when we are concerned that a student may require specialized education and would qualify either under social emotional disability or autism spectrum disorder or another developmental disability? And this kind of differentiation can be very complex for a lot of reasons that we'll talk about today. And my hope is that you'll leave this webinar with some deeper ideas about how trauma and extreme stress can impact the social functioning, communication development, and the behavioral flexibility of children. Also want to be sure to continue to return to what autism spectrum disorder is and how it impacts those same aspects of functioning, social, communication, and behavioral flexibility. We will identify a set of assessment practices that we've learned about from the literature that we hope you'll consider if you are facing this differentiation in your educational identification process. And we also hope that you'll find the resources that we're providing in this webinar to be useful in your practice. So let's go ahead and get started. I'd like to begin by talking about the definitions, how children will present, the overlap, and the distinctions between childhood trauma and autism spectrum disorder. I spent a lot of time digging into the literature to make sure that we had the most up-to-date information. And one of the first things I learned is that this is a field where we need to do a whole lot more work to become more effective to support children with complex histories. So let's begin by looking at definitions. When we consider what trauma is, it's defined by the Diagnostic and Statistical Manual as exposure to actual or threatened death, serious injury, or sexual violence. The DSM-5 definition, which is what clinicians rely on, also includes witnessing events and mentions generational trauma as well. Other sources have gone into more detail on what a definition of trauma should be for children. The APA Presidential Task Force on PTSD and Trauma in Children and Adolescents, approximately 10 or so years ago, included various forms of maltreatment, which would be abuse and neglect, exposure to violence, war, ongoing conflict, family dysfunction, severe victimization by peers, pervasive or significant public health problems, natural disasters, famine, environmental episodes, extreme poverty, and prolonged and complicated grief. So you can see that our way of thinking about trauma can differ by where we practice, and psychologists and social workers really want us to be thinking more broadly about how stress can impact child development. When we look at the definition for an autism spectrum disorder, you'll see here how the DSM-5 defines the condition, and as we've discussed in previous webinars, each state has their own definition for an autism spectrum disorder that is couched under IDEA. Now let's look a little bit more deeply at each of these two conditions of childhood and see how they may differ and also how they may be similar to each other. So first, let's talk about etiological factors. In other words, what causes the condition? So in the case of childhood trauma, the experience of extreme stress, particularly in the early years when the brain is doing a lot of work to develop itself, making connections and pruning repetitive connections, experience changes the neurobiological infrastructure of the brain and nervous system and can significantly impact development. So in trauma, we are likely to see a child who's born into the world with a healthy neurobiology, and then once exposed to extreme stress, which could be in lots of forms as we just described, acquires neurobiological differences because of their experience with stress. In other words, the experiences change the way the brain is functioning. Sometimes, if the trauma is rooted in family violence, parent abuse, or neglect, we will also see a dysfunctional parent-child relationship that's trying to adapt and manage and prevent further trauma. Now, in autism spectrum disorder, we have a different scenario in the sense that as a field, we believe that children are born into the world with an autism spectrum disorder, even though we're not able to identify it until they're 2 to 3 years of age. In autism, it's thought that the neurobiological infrastructure is built differently. The connectivity of different regions is functioning in an individual and idiosyncratic way. And this neurobiological infrastructure difference is what significantly impacts development. So in autism and in trauma, you have differences in neurobiology to contend with. In autism, we believe somebody is born with those differences. In trauma, those differences are acquired. And in autism, of course, not all the time, but we often assume that the difficulties that we see are not rooted in dysfunctional parent-child relationships. When we look at the literature on biology, comparing children who were exposed to extreme stress and trauma or those who were born with an autism spectrum disorder, what you notice is that you have very similar regions of the brain that are impacted in both disorders. So we could go into this in a lot of detail, but I want to make sure that I stay practical. What I think is most important to take from this is that the neurobiological differences tend to focus on the parts of the brain that help with fear and emotion and memory and arousal and alertness. So we see differences in amygdala volumes, which is the part of our brain that helps us recognize fear and then activate to be able to respond to that. We also see dysfunctions in either the HPA axis, which is strongly impacted by stress or trauma, in the sense that children who experience prolonged stress often have a blunted or sometimes very exaggerated cortisol experience, cortisol being a hormone that helps mediate behavior. So dysfunctions in regulatory systems really characterize both conditions, but those dysfunctions could be different in quality and also occur in different parts of the brain. It's also important to mention that while there is scientific evidence for all of the things you see on your screen here, there are also inconsistent sources of evidence that in both the case of trauma and ASD would posit a different set of findings. So this literature is rich and deep and sometimes contradictory. But it's important to know that in both conditions, we see differences in prefrontal cortex and we see differences in immune system markers, neurotransmitters, and regulatory systems. There are also some findings that suggest that telomere length, which has to do with the ends of your chromosomes, is shorter in both ASD and trauma, and that is thought to be associated with an aging process where the brain is less flexible in its pruning when telomere length is shorter. So all of that to say that we do have some overlapping biological findings between these two conditions. Another place where autism and childhood trauma have a lot in common is that the presentation of the condition is going to differ depending upon a lot of different characteristics of the child. So what you can see here is that developmental functioning, the severity of the condition itself, social experience, any co-occurring conditions like a mood disorder, temperament, age, sex or gender, and access to treatment all have been shown in the research to impact how autism or trauma presents in a particular person. There are also secondary factors to consider. What we mean here is how the experience of having the condition impacts the person's behaviors over time. So in trauma, the history of hurt, mistrust, fear, and needing to be constantly on the lookout for things that might be threatening, what we call hypervigilance, can lead to adaptations that help the child feel safe in the moment, but are probably not so adaptive in the long run and actually become somewhat symptomatic as being an adverse response to stress. So in trauma, as a result of trying to deal with all of that hurt, mistrust, fear, and hypervigilance, you may see social disinhibition, where a child is overly friendly with people that he doesn't know well, almost like a lack of social boundaries. We can also see social withdrawal, not responding when others are attempting or maybe shutting down, particularly emotionally. There's a lot of literature that backs up compartmentalizing certain feelings in certain places so that you don't have to deal with them throughout the day. And for some children, there are observations of disengaging or dissociating when they come upon a trigger or something that reminds them of that painful memory of abuse or extreme stress. So you may get a shifting to an internal state where they're no longer really with you in the moment. There's also the phenomena of masking. And what we mean by this is when a person recognizes that they're struggling with something, so they do whatever they can to compensate and appear like they're like everybody else. If there's a concern or a problem, they try to push it down and they try to fake it till they make it. There's a lot of literature in the childhood trauma field that suggests that some children, particularly in the elementary years, will work very hard to minimize any impact of abuse or neglect, for example, in the home, often because they are wanting to protect the person who may have abused or neglected them. So masking can be an exhausting thing for a young person or an adult to try to maintain over the long haul, and it can also make it very difficult to get a sense about somebody's authentic struggles. In autism spectrum disorder, the secondary factors are somewhat different. Here, you may have a person with a history of being overwhelmed by social information that doesn't necessarily make sense intuitively, sensory aspects of the environment that are hard to cope with, and that can lead to adaptations which protect the person in the moment but aren't so adaptive in the long run. And for autism, we're often looking at insistence on sameness, withdrawal, self-stimulating behaviors, and over-reliance on rules and systems, and yes, we also see masking, particularly in the adolescent years, and particularly with females, according to the literature. So in both conditions, trauma and ASD, there are the core impairments that impact functioning, and then there are the aspects of living with the condition that can actually complicate the presentation. Both conditions also have a distinct set of evidence-based interventions that have been shown to be helpful to promote healthy adaptation for children. So what you see here is a brief list of evidence-based interventions for childhood trauma and a brief list of some of the evidence-based interventions for children with ASD. When we get to the resource section, I'll share with you a resource for evidence-based interventions for both conditions, web-based resources that I think you may find very useful in your practice. When we look at this list, it's a reminder that yes, it is important to try to differentiate if a person is experiencing trauma, if a person is experiencing ASD. And it is possible that you'll be able to rule one out and recognize that one is the predominant factor driving a child's need for an educational eligibility. However, I'd also encourage you to consider that oftentimes, sadly, we are looking at complex children who have experienced both trauma and a neurodevelopmental disorder such as autism. So it turns out that although neurodevelopmental disorders originate in the brain, they can be worsened or improved by their psychosocial experiences, by their interactions. So early experience sculpts our brain, especially our prefrontal lobes, especially our social and emotional responses. And if a person with a neurodevelopmental disorder grows up in a sensitive, responsive environment, they are likely to develop better skills. If, however, they are exposed to extreme stress or trauma, their core symptoms of the neurodevelopmental disorder can actually worsen. Now, there are many vulnerabilities associated with having a neurodevelopmental disorder, such as autism, which increases the risk for physical, verbal, and sexual abuse. So in the case of autism, not necessarily understanding another person's intentions could make you more vulnerable. Difficulties complying or understanding language or following what an adult asks you to do could actually put a child at increased risk for abuse or neglect. In fact, unfortunately, I'm not sure actually there would ever be any, fortunately, in any study of childhood trauma, but children with neurodevelopmental disorders have been shown to be 2 to 7 times more likely to experience maltreatment or family or peer violence than their same-aged peers. And in one study that looked at a population-based sample, they examined whether having an intellectual disability changes the vulnerability or risk of a child with autism for maltreatment. And what they discovered is that if a child has ASD, it doesn't matter if there's an intellectual disability in the picture with regard to their risk for maltreatment. Kids with ASD were at greater risk to be involved in social services reports and were more likely to have substantiated maltreatment than typically developing peers, regardless of their intellectual status. Children with ASD who did experience substantiated maltreatment, meaning that it was proven, were very likely to show significantly increased rates of acting out behavior, particularly aggression, hyperactivity, inattention, and temper tantrums. So, co-occurrence of trauma and ASD is something that we have to consider, and it's quite possible that a child that you're evaluating with a complex presentation has actually experienced both. So let's turn our attention now to how children may present when they have experienced trauma and when they have experienced an autism spectrum disorder. And I'm going to try to organize this discussion by talking about 3 aspects of functioning that impact both conditions. And those aspects are self-regulation, affect, and social synchrony, your ability to be reciprocal in a fluid manner. So let's talk about self-regulation first. Well, there's a pretty deep literature about the overlap in symptoms or behavioral markers of both of these conditions in childhood. You're quite likely to see all the things you see here on this slide across different ages in childhood and adolescence if there is trauma as well as if there is ASD. Now, granted, it's important for me to mention that, of course, any individual child is going to present differently. These are overlapping symptoms that tend to be observed in children with either or both conditions, but you will not see all of these things in every child with any condition. So the overlap then is in impulsivity, poorly regulated arousal and alertness, inattention, sleep problems, temper tantrums, emotional and behavioral regulation difficulties, low frustration tolerance, and perseverative behaviors. So you can see that many of these things would be associated with dysfunction in the frontal lobes of the brain, where we are really looking at those regulatory processes. So the overlap in features that you can see in the self-regulation domain are pretty significant. Where children with both of these conditions may differ is what we want to cover here. So in childhood trauma, in general, triggers appear to come from nowhere, and the child may become dysregulated quickly. You may hear definitions or descriptions of intermittent explosiveness, where high reactivity is thought to characterize this dysregulation. Whereas in autism spectrum disorder, it's not like triggers can't happen. It's not like there can't be intermittent explosiveness. But in general, in autism spectrum disorder without trauma, we usually see clear antecedents to most problem behaviors that are somewhat predictable. So we can oftentimes see something in the environment that makes sense to us that may have led to a problem behavior with a function of, say, escaping a demand or seeking attention. Whereas the triggers in trauma may be very difficult to identify or interpret. Children who have experienced trauma tend to be very aware of cues in their environment. They don't always interpret them correctly, but they're hyper vigilant, hyper attentive to what's going on around them, particularly a lot of checking in with adults to see if they're safe or not safe is the thought. Whereas in ASD, you usually see a limited use of social referencing to co-regulate, and there's less vigilance or interest in what others are thinking about when trying to regulate themselves. In trauma, you may see dissociation where the child seems selectively attentive, as if they have just checked out. And staff may feel like it's on purpose because it looks selected, but it is probably a reaction to strong physiological cues that they're just overwhelmed and so they shut down. In autism spectrum disorder, we tend to see problems disengaging their attention from one topic or thought to another, and that disengagement might look like dissociation, but it's thought to be a bit more of a shifting of attention problem and less affectively charged. In trauma, there are repetitive, perseverative behaviors, sometimes ruminating statements that they'll repeat, or an interest that they become overly interested in. And the literature suggests that children who have experienced trauma often choose to overly focus on things that cause them fear and distress, as if they somehow have to engage with it in order to adjust to it. Whereas in autism spectrum disorder, perseverative behaviors are often interesting, fun, and sometimes self-calming for a person with autism. More of a pleasurable experience to the individual and less distressing than you may see in trauma. In childhood trauma, you may see that when the child is stressed, they become frenetic about getting basic needs met, like eating or affection. Whereas in autism spectrum disorder, we tend to see an increase in repetitive body movements or in repetitive topics when they are stressed. In trauma, it's thought that the memories of that past stressful event get somaticized and become what clinicians call body memories. And a child may not be aware of the triggers that are causing these body memories, but they pick up on the bodily sensations, and that's part of what leads to their disorganization. In autism spectrum disorder, many of the children that we see lack body awareness and aren't necessarily picking up on the cues that their body is giving them. So whereas in both conditions there tends to be a misinterpretation or a misunderstanding of the cues, my thought is that in ASD there isn't as much sensitivity to some of those bodily cues in the moment. There's like a separation between cognition and body, oftentimes in people with autism. So now let's move on to the area of affect or emotion. There is a lot of overlap here between children who have experienced trauma and those who are born with autism. You may see irritability, which could be related to fatigue, frustration, trying to make sense of a world that is not very accommodating, or simply just being worn out by being so vigilant in the case of childhood trauma. You may notice a flat or detached affect, kind of a serious face like you see on the images here on the slide. For some children with both conditions, if you try to introduce the idea that they're feeling sad or they're feeling angry, they may reject that and deny that they're having that negative affective experience. That's something I've seen myself in children with either condition. It seems quite protective in trauma, whereas in autism, to me, it sometimes seems like a misunderstanding. Like if they don't acknowledge it, it isn't happening and that somehow negative affects are bad and you don't want them. There's a tendency to not understand in autism that all of our emotions are complex, they co-occur, and that we all experience good feelings and bad feelings. It's just a part of being a person. In both conditions, there's substantial difficulty reading affective cues. Some of the research suggests that a child with trauma is monitoring and picking up cues, but misinterpreting them, more likely to see threat when it isn't there. In autism, we often see that they don't know quite where to look for those affective cues, may spend more time looking at the mouth, for example, when someone's speaking, instead of at the eyes, which is where a lot of emotion is communicated. In both conditions, we see difficulty labeling feelings, describing a range of feelings, and talking about feelings beyond just like an encyclopedia definition. So there's difficulty expressing or communicating about emotion, which is a phenomena called alexithymia, which we'll discuss later because it turns out there are a few measures of that trait that may be helpful in our ability to understand children with a complex history. Then, because of this difficulty expressing feelings, it's thought that children with either of these conditions could then act out, sort of displace their distress, and become either aggressive or self-harming because they can't deal with the emotions that are so unraveling and disorganizing to them. When we look at affect and how it differs between children who've experienced trauma and those with autism, we have a couple of findings that we can integrate into our practice. In trauma, it appears that many children who have been exposed to abusive caregivers or family violence tend to show a muted response to big emotional experiences. They may become very, very guarded around events that are supposed to be special and fun, like going to an amusement park or the holidays. You rarely see that sense of unbridled happiness or exuberance in some children who've experienced significant and persistent trauma. And that muted or sort of constrained affective response is thought to be self-protective and also thought to kind of keep that HPA axis dysregulation kind of at a minimum. So it's biologically adaptive as well to not respond in a large way to emotions. In ASD, we often see exuberance quite often. There can be unbridled happiness at all kinds of things. And a child who has not had to deal with excessive stress in childhood is likely to show very positive responses to big events. In trauma, we tend to see strong reactions to shame. Shame and guilt and those secondary emotions tend to be a central feature of the emotional landscape of a child with trauma. What this may mean is that a child may apologize way too often for things that really aren't her fault, may lie pretty easily, may lie often because it's a way of avoiding shame or disappointing a caregiver, and in general may feel overly responsible that everything go okay. In autism spectrum disorder, we see a delayed understanding of shame, which is usually understood around 4 years of age, and they're unlikely to be preoccupied with what other people think of their behaviors or choices before the teenage years. Now, you may see that in some children who are really, really bright, but in general, secondary emotions like shame and guilt tend to be delayed in their onset and don't preoccupy an individual with autism who hasn't had bad experiences that would bring about that kind of shame spiral that we hear about in childhood trauma. In trauma, you will likely hear about nightmares, flashbacks, even hallucinations, where the person's sense of reality and current emotion get mixed up with what happened in the past. So a person's affect in the moment may not be as related to what's going on around him, but is strongly related to what happened in the past. And many children with trauma show this heightened threat perception. They're fearful at unexpected times, and it may be difficult to predict when they may need more social support. In autism, we don't usually see nightmares or flashbacks. We may see heightened threat perception, particularly if they also have an anxiety disorder operating within autism. But in general, autism differs from trauma in the affective domain in how they express emotion in their tone of voice. Now, this is true for approximately 60% of people with autism, where they have an unusual prosody, which has to do with your voice tone, how you modulate it to add affective cues, how you use volume, or even the pacing of your speech to indicate your affective state. Well, for more than half of people with autism, it's thought that unusual prosody, a lack of affective modulation, or affective cues that feel like a mismatch, those sorts of things, along with kind of a sing-songy voice tone or a mechanical voice tone, those are much more strongly associated with autism and aren't thought to be a part of trauma. What you may see in trauma is kind of a flat or serious, non-varying voice tone, but it won't have the unusual rhythms and pacing voice tone modulation issues you see in prosody. Unless a child with trauma also has a stuttering or disfluency condition, you usually see pretty fluid verbal speech. In autism spectrum disorder, you may see disfluencies where even if the person isn't actually stuttering, they may take breaks in their breath at odd places when they are talking, or they may process language more slowly than others. It's also thought that in autism spectrum disorder, while they may have a heightened threat perception to something like losing a favorite object or, not being able to do something they're really counting on, they're usually not very attentive to the affective tone in the room. So they may not pick up on the stresses that other people are feeling that children with trauma might be hypervigilant to. And now let's talk about how these two conditions overlap when it comes to social synchrony, or that back and forth feeling of connectedness or reciprocity between two people, where the timing of your interactions and the two-way nature of social interaction becomes important. So as you can see here, there are several aspects of the presentation where children with both conditions may be avoidant, may withdraw, sometimes at unexpected times, may seem to be seeking control of a situation, directing others a bit more than other children might be doing. And they may be prone to some pretty strident or insistent narratives, which could seem out of context. So sometimes in autism, we can talk about an exaggerated sense of justice, where if they see unfairness, they need to discuss it. Well, it's thought that in trauma, many children have had a lifelong history in their short lives of not feeling heard, not being listened to. And so some of them may lead with more insistent, strident, almost intrusive kinds of narratives that can seem very one-sided and overly intense. But that may come from their experience of not being heard. Children with either condition are likely to misread social cues and behave in a way that seems out of context because they're relying on the wrong information. They often, in both conditions, do not recognize the impact of their own behavior on other people, and it may seem as though the social skills they're using, the pro-social behaviors we want to see, might feel sort of forced or as if they have cognitively told themselves to do something, not quite as intuitive or free-flowing. So let's take, for example, sharing in a preschool classroom. A child may reluctantly, yes, go to give a toy, but if a child's experienced a lot of stress and trauma, they may take it back as quickly as they wanted to give it. So they're trying to do the right thing, but it just doesn't feel quite right. And in autism, we often see that they learn what the right social skills are. They can talk about them, but putting them into action in the moment, in a dynamic and rich way, is where the challenges are in developing socially reciprocal relationships. So how are these conditions different in social synchrony? Well, first off, in trauma, if it's related to abuse or neglect or some sort of dysfunction in the parent-child relationship, attachment problems will be evident in the child's behavior. And when you're looking for attachment problems, there are particular measures you can do, but in general, you're looking at, can the child allow the caregiver to come and go and then greet them when they return in a secure way? That would be a secure attachment. There are also insecure or avoidant or anxious attachments where there's a bit of a push-pull or a lack of trust when the caregiver re-enters, or there could even be a lack of noticing that the caregiver has even left. Attachment problems may be seen in trauma where children become quickly attached to a new person when they actually don't have a deep relationship with them. In autism spectrum disorder, there's a pretty deep set of research on attachment problems, and they are rarely evident when there hasn't been trauma or stress. So whereas children with autism do lack natural biological synchrony with a caregiver, many times their best quality social relationship is with familiar and responsive parents, and attachment problems are rarely the root of their social dyssynchrony. In trauma, children are usually particularly attentive to affective cues and will pay attention to the faces of caregivers, even fleetingly, to make sure that they can trust them. In autism, we see diminished attention to faces, particularly in the early years. In trauma, there is evidence that children learn to understand another person's perspective in the cognitive area, what they might be thinking about, what they're looking at. Those sort of objective cognitive aspects of intersubjectivity are thought to be intact for most children who've experienced trauma. Where they have difficulty is in accurately understanding another person's emotional state and knowing how to manage that. In autism, we usually see problems in both kinds of intersubjectivity, difficulty understanding the perspectives, the thoughts of another person, as well as the feelings of another person. And these can get better with age, but particularly at younger years. In trauma, you are more likely to see the child attempt to imitate the behaviors of others, particularly peers. It's also thought in the literature that for many children with trauma, they have less social experience than other children, and they may not see a wide variety of behaviors to model. So while the richness of their imitation may not be particularly striking, they are more likely to attempt to learn new skills through imitation than their peers with autism without trauma. In autism spectrum disorder, we see some unusual ways of interacting with adults, particularly at young ages, where it's almost like people feel like they're being treated like objects, where a child sits on an adult's lap as if the adult is furniture, or may use the adult's hand like a tool, taking the child's hand, putting it on the adult's hand, and then moving it without looking at the adult to retrieve a toy or get help. We are much less likely to see those behaviors if trauma is the better reason for the problems that we see in a child. And in trauma, we are more likely to see an overly familiar style with strangers and a lack of social boundaries. Often, a child with trauma will behave differently with different people, and this is a really important point for us to consider. For a child who's been through excessive stress, particularly if it relates to abuse, neglect, or family violence, they will behave differently based on their level of trust with the person. Whereas the social difficulties in autism should not be varying significantly across people. The neurobiology of autism means that those social impairments are kind of baked into the system and are likely to express themselves with preferred and non-preferred people. Now, this is not to say that children with autism don't, behave in a richer or higher quality way with some people over others. You can certainly see that the quality of the relationship is going to influence their overall functioning. But in general, The consistency of the social impairment could differ between childhood trauma and autism, where kids with autism, because these are neurobiologically originated behaviors, are likely to have social impairment across adults and children. Children with trauma, depending on how excessive that trauma was, how much their neurobiology has been influenced, could be inconsistent in their ability to relate to others. Now that we've looked at what the literature can share with us about the overlap and the distinctions between the two conditions, let's take a look at what's recommended for assessment in a clinical or an educational setting. Well, the first important point to cover is that the state of the research on assessment of trauma for people who may have a developmental disability or a neurodevelopmental disorder, those two things could be used interchangeably. The bottom line is that we actually don't yet have measures that are trauma informed that have been extensively validated in people with neurodevelopmental disorders. So we do have existing measures that have been well studied to look at childhood trauma, but we may need to adapt them for use with a child with a neurodevelopmental disorder. There is a new measure that we will give you a link to in the resource section that looks really promising to me. It's something called the Interactive Trauma Scale, is under development right now. This is a web-based touchscreen application that uses a lot of visuals to assess trauma symptoms in youth with ASD. And I think we should pay attention to that particular measure. I like that it would be a way of getting self-report through a modality that the children may be interested in accessing. So as far as assessment goes, we need to see more tools carefully validated for use with the population we're talking about. And for now, we can use existing tools, but we'll need to adapt them. So what are some assessment practices we should keep in mind when we are wondering if a child's difficulties are associated with trauma or an autism spectrum disorder, or possibly both? Well, the very first thing is to really spend a lot of time gathering information about the child's history. It's important to do this by interviewing more than one caregiver if you can, by trying to do a deep record review, and to basically lay out a timeline that would show important historical events, when abuse or trauma happened, when there was a significant loss, perhaps a death, if there were moves or transitions, significant changes in the family, or a loss of social support. It's also important to consider along the timeline any re-traumatizing events that we would need to recognize. It's also very important as you're doing these interviews to make sure you know if the stressful events continue to be a part of the child's life. And in this interviewing process, you may be identifying abuse or neglect for the first time and may need to actually may need to act on your mandated reporter status and let people at Child Protective Services know about what it is that you've discovered. It's also important as you look at your timeline to consider how the child's behaviors may have changed before and after the traumatic event. So if you were to see, for example, social communication and flexibility problems from the age of 1.5 through early childhood, and the trauma happened in 3rd grade, then it's possible that autism is in the picture because you have this early history of developmental problems that can't be attributed to the known stressor. When you're doing this interview, you often need to have good clinical skills. So trained social workers, counselors, school psychologists, nurses are often the best people to do these interviews because they've been trained how to ask difficult questions. You want to phrase your questions in a really specific, clear, and objective way. If you're talking to a child, has anyone ever hit you and left a mark, is a much better question than have you ever been abused, for example. You want to also see what you can figure out about a child's developmental trajectory of skills. Does it look like skills continue to be built on over time? Or was there ever a period of regression, a loss of skills that they used to have? So you may see in trauma or in autism regression in things like toilet training or even language skills that you'd want to understand. Second important practice in assessment is to obtain reports from multiple informants. This differentiation is so complex that you really do need to hear from hopefully multiple people in the child's home who can help you understand history and current functioning. It's also really great to get teacher or child care provider report as well as youth self-report. And that's true regardless of age and regardless of the severity of the developmental conditions. So if we're working towards self-report with somebody who isn't using language well, we may be using play or pictures to try to get a sense of things. There may be limits on what you can learn through self-report, but it's important to always remember that the child himself has important and unique sources of information. And if we can ascertain that information in whatever way, it can be helpful as we put all the pieces together. Now, you definitely need to be mindful of the potential problems interpreting self-report responses that are provided by youth who have symptoms of autism. As you can see here, self-report in children with autism, based on studies of kids 7 years and older, show that they tend to be overly literal in their interpretation of items on questionnaires. They might focus on a detail in the question and kind of miss the main point. So it can be very helpful to go over a youth self-report questionnaire in person or using visuals that they choose from a range of facial expressions to agree to disagree. There's also a tendency for youth with autism to provide more extreme self-report scores on behavioral measures than typically developing youth. Sometimes those are extreme where they're seeing themselves as completely not affected by a problem. Other times they may report the problem to be the worst it's ever been. There's also a tendency in children with autism to deny experiencing some symptoms they view as negative. So be ready to be stonewalled there occasionally. When you're looking at the differentiation or co-occurrence of trauma and ASD, it's a very good idea to include reliable and valid tools to screen for general mental health. And you'll need to choose a tool that's appropriate for the developmental level of the children you're working with. So if you're working with young children, the BITSI or the ASQ can provide you with a validated social emotional assessment that can help you understand the child's functioning. And these measures in early ages are parent report. You then can also access other measures that are good for the school years. And I've included one here, the Strengths and Difficulties questionnaire, that I like very much because it can inform the emotional landscape of a person with autism or trauma. You get parent, teacher, self-report versions, and it has 5 scales which tap really relevant areas for what we're discussing here today. These tools also tend to exist in multiple languages, and all of the tools that I've mentioned have a very brief administration time, and some of them are free, others cost some money. It's also important to screen for child trauma specifically and the features that could be associated with trauma. So your mental health screen will give you kind of a big picture of the child's internalizing or externalizing challenges. This type of screening involves different ways of accessing caregiver report often, or in some cases, observing the child in different situations and then noting your opinions, as in the case of the children's alexithymia measure. And sometimes these measures involve brief interviews with the child or youth himself or herself and can give you important information. The life events checklist and the trauma symptom checklists for children tend to be used most frequently in child welfare systems and in school systems. They are relatively brief and can allow you to understand if the child might be at risk for trauma or extreme stress. One of the resources that I hope that you will investigate is the National Child Traumatic Traumatic Stress Network, which is a wonderful web-based resource designed to provide professionals and lay people a lot of information, training webinars, and tools that will help support people with complex trauma. So they present an informal screening tool for trauma that can be given to a parent. And if 2 items or more are identified, then it's recommended that a more comprehensive trauma social emotional assessment be conducted. So you might decide you want to use a screener like that. We also see in the National Child Traumatic Stress Network a few more measures that can be used separately for young children, 0 to 5, versus those who are of school age years, 6 to 18. This is just a snapshot of part of it. They're about 2 pages long and allows you to gather information prior to speaking to a parent about what kinds of stresses and traumas the family or the child may have been exposed to. Once you've done your screening for general mental health, your screening for trauma, you've understood the developmental history, if you have positive screens, you need to follow up with a full and deeper evaluation. It can be very helpful to include measures of the domains of functioning I have listed here, but that is an individualized decision that the multidisciplinary educational team will determine as they put together their evaluation battery. But understanding the child in each of these areas, particularly in the area of pragmatics, communication skills, adaptive behavior, and overall intellectual functioning, could be extremely helpful in informing not only your understanding of the child's needs, but the appropriate educational eligibility category. Perhaps our best tool in the school system is our ability to be able to observe the child with multiple people in different contexts. So observing a child frequently for short periods of time is strongly recommended for assessment of trauma because of the inconsistency of presentation. It's important to observe the child in both structured and unstructured settings. You want to see them with peers and adults, one-on-one, groups, larger groups, and sometimes it's very helpful to structure your observations so that you remember to look for specific signs of autism or specific signs of trauma. You may also find that you want to pay attention to motoric behaviors. I haven't mentioned that yet, but for many people with autism, there's a distinctive gait or posture that can be somewhat stiff, and some motor planning problems like using 2 hands together to do things efficiently. Those things can be very common and are not as likely to be associated with trauma. So in your observations, yes, you're looking at social and emotional responses, you're looking at play acts, you're looking at social initiations, you're looking at pragmatics and how richly verbal and nonverbal behaviors are integrated. But you also want to keep an eye out for some of the aspects of either condition that may be unique. Now, there are a couple of different tools you could use to guide your observations. The Childhood Autism Rating Scale has a clinician checklist that you can use to basically integrate all your observations with what you've learned from parent, teacher, or self-report into one particular measure. Then there are also some pragmatic observation tools that will help guide your efforts to look at communication. So one of the ones that I would like is the functions and forms checklist that the Colorado Department of Education has posted on their website. I'm finding that in observations, and I'm wondering about trauma or autism, paying attention to the range of why the child communicates and how they communicate, what we might call the functions of communication and their forms, becomes really important. So we tend to see a restricted number of forms and functions in autism and may see a richer variety in a child with trauma without autism. As you are embarking on your full evaluation, it's important to also use reliable and valid tools to assess autism symptoms. And we've spoken about this in previous sessions, so I won't go into it in detail here, but rather refer you to other webinars on autism identification. But a couple of the tools that we have found to be useful in assessing autism symptoms will be presented in the next few slides. So you could choose to use the social responsiveness scale, which has a parent and a teacher form, as well as a self-report if the person is old enough. There's the Childhood Autism Rating Scale, which, as I mentioned, has the clinician observation form. It also has parent and teacher checklists and has two different versions depending on the overall intellectual capacity of the person. The Autism Spectrum Rating Scales are also a good tool for understanding what behaviors associated with autism may be evident at home or at school. And then the Autism Diagnostic Observation Schedule is one of our best tools in the clinical world because it allows us to do this interactive, play-based assessment of autism symptoms. However, as we've talked about in previous webinars, it tends to not be used often in school systems because of the amount of training and ongoing reliability calibration that's required. So if your district uses it and people have been fully trained to the specifications of the measure, it can be a very helpful tool, but it's not one that you can just pick up and use without a lot of training and certification. So as you have thoroughly pursued all of your assessment measures, you will then want to come together with your multidisciplinary team, not in the formal meeting yet where you're bringing in the family, but I would recommend in these complex cases that key members of the school team get together and talk about history, culture, and family issues. Summarize and interpret your data together. Come up with lists of very specific examples of your concerns. So you are not formulating a diagnosis at this point. I shouldn't say diagnosis. You're not formulating an identification at this point, but you are talking it through, coming up with your own way of thinking about the child's presentation and making sure you're prepared to be able to talk to the family and other members of the team about what you've observed or learned from report. So prior to meeting with the parents, take a look at your data and ask yourself, do I have evidence to support that the child has experienced trauma and may qualify under a serious or significant emotional disability? You also want to ask yourself, is there evidence to support that the child meets criteria for an autism spectrum disorder? And in both of those questions, you'll look at your state's eligibility criteria for those two conditions. Now, sometimes the evidence is going to support both conditions. So you'll want to talk as a team about what your thoughts are regarding which one has the greatest impact on educational functioning. And I would encourage you to consider identifying the other as a secondary condition so that future teams can really understand the depth of complexity that you're trying to narrate in this educational identification process. Then you'll want to meet with the family in your formal educational eligibility discussion and decide together on the appropriate educational eligibility. As we've spoken before in our webinar on communicating with parents, it's so important to be sensitive to the parents' feelings and experiences, and if at all possible, to limit the meeting to just a few people so that the parent is not further traumatized if they also have been a part of the trauma. So our emotional sensitivity needs to be particularly finely tuned in these conversations, and we may want to have an initial meeting with the family to talk about things prior to a formal educational eligibility meeting, as long as that is consistent with your district's policies. When you are discussing possible educational eligibilities of trauma or autism or both, try to be direct and clear, really specific about your observations, be objective and non-judgmental, and try to explain that understanding the root of the child's problems will help guide the choice of appropriate interventions. Present your body of evidence and be open to talking about which educational eligibility category seems to be the most appropriate for describing the origin of the child's difficulties. You will want to decide together with the family if SED or ASD is a better fit as the primary eligibility. And as we've mentioned in previous webinars, in my personal opinion, What you choose as primary or secondary is not nearly as important as making sure that you document and describe your concerns so that people can be choosing interventions and approaches based on a deep and nuanced view of the child. So the eligibility category is not gonna capture everything that impacts a given learner. You want to make sure your narrative is the clearest and most detailed that it can be. So in conclusion, it's quite challenging to approach an educational identification wondering if the child's presenting with problems because of a history of trauma or autism or both. So this differentiation often does require a comprehensive multidisciplinary evaluation that usually needs to be repeated over time. So there's an ongoing assessment piece to this. Co-occurrence of the two conditions, as I've said, is not only possible, it's sadly likely. So don't rule anything out. Particularly, you're likely to not get a complete history. It may not be definitive. So consider which conceptualization can be most helpful for understanding the child and selecting interventions. I do recommend focusing on developmental history, and the literature is really clear in child stress and trauma that if we can understand when the trauma occurred and then look at when concerns about the child's social and communication first emerged, that will help us with this differentiation. And then we also want to always keep in mind this idea that in autism spectrum disorder, you're likely to see consistent and persistent problems in the major symptom areas. So a child who can be really reciprocal and interact very nicely in a back and forth way in one situation, but not in another, is much less likely to have autism spectrum disorder. Those impairments are usually universal. Sometimes a child with a history of trauma will present as autism-like, and developmentally sensitive interventions that target relatedness and parent-child interactions can promote some incredible progress. And the literature suggests that when autism-like behaviors are present, but they're rooted in trauma, that progress is likely to be faster than if the child was born with neurobiologically based autism. So in this way, you need to revisit these evaluations as a child with trauma as the origin for difficulties may improve significantly over time. Even with a trauma history, if the child is showing qualitative differences in social reciprocity, nonverbal communication, and behavioral flexibility, it's appropriate to identify autism as an educational eligibility. It may be that even with the trauma history, it's the features of autism that are interfering with learning and independent functioning at school. In that case, you'd want to identify autism, and you may recognize that outside of the school setting, that may not be how people think about it, but it could be a very, very helpful way of approaching the selection of interventions. So I think it's pretty important to remember that our job is actually to look at the current concerns and try to understand the root of the problems accessing the general education curriculum. While we would like to know how these concerns came to be, the etiology of the problems, as that would help us understand if they came from trauma or from autism, if the child is presenting in a way that's consistent with the educational definition of ASD, it really should be included as either a primary or secondary eligibility category. Your hard choice there might be to be able to know if you have enough evidence to establish a serious emotional disability based on the trauma. So technically, we don't need to understand the etiology to make the call, but it does inform us. I just don't want you to get stuck there. So now as we end up, I just want to share with you some resources I hope will be useful in your practice. Here's the link to the National Child Traumatic Stress Network, and I think you may find the Toolkit for Educators and their Screening and Assessment Tools section to be particularly useful. They give you links to public domain measures and provide a really good expert review of the pros and cons of each tool. The tools that I've mentioned have been cited in our reference list and are also listed here by publisher. And then I wanted to let you know that the Affirm website put out by the University of North Carolina provides a wonderful repository of evidence-based interventions for autism and a lot of trainings on how to use those resources. So check that out if you're interested. You may also find the book by Fogler and Phelps to be helpful. If you would like to learn more about that tablet-based assessment of trauma symptoms from Kennedy Krier, check out this link. And I also found a very family-friendly article on trauma and ASD, which I thought you might find useful. So I hope that this talk has been helpful as you embark on serving complex students with complex needs. The slides are available to you. We will also put links in the chat to some of the handouts or things that we have found useful in our research on this topic. Thank you very much for your time and attention, and I wish you well on this difficult, challenging, and very important work.